What about healthcare providers who are not physicians and not hospitals? We should take time here to recall that there are many other types of providers out there and have a brief look at the kinds of arrangements you'll see for them. It's very handy that most of these arrangements will bear some similarities to what you'll commonly encounter for physicians and hospitals, so that'll help us. There are many kinds of professionals out there to start with. There are nurses who play essential roles throughout the healthcare system, technicians with skills and training to operate particular pieces of equipment or perform certain services, also very important. Physician assistants, nurse practitioners, physical therapists, dentists, optometrists, chiropractors, nutritionists, podiatrists. I could keep going, but I better stop. When these kinds of professionals are hired by organizations like physician practices or hospitals, they would normally work for and be paid by the organization. A common model would be a salary model, like a salaried physician in a group practice. But when other professionals set up practices on their own, think about a dental practice or an optometry practice, these would look a lot like physician practices. There would be a practice structure that would provide facilities for their work. They may make arrangements to work with insurance companies or intermediaries, though sometimes these professionals might also work outside of normal insurance arrangements and have patients pay them directly for care. When they work with intermediaries, the contours of payment would often be similar to those for physicians, fee for service often, or other kinds of arrangements. Besides professionals, there are also other kinds of organizations, not just physician practices and hospitals, but others too. There are independent labs, for example, and independent diagnostic facilities, independent ambulatory surgery, physical therapy, long-term care, and many others. From a system standpoint and a payment standpoint, these will often have similarities to hospitals in terms of arrangements and payments. They'll normally have to form some affiliation with one or more intermediaries, and how they do this will depend on the system they're in and the norms of operation in that system. Then they'll need payment arrangements when they provide the facility component of care, which will generally follow contours similar to hospital facility payments or sometimes similar to physician payments. Maybe they'll make fee-for-service arrangements using a charge master or maybe a fee schedule. Those can be common, though depending on the specific type of facility and the context, other things too can be used like per diems or even DRG-like things. When you encounter these other kinds of providers, which could be often, it can take some sorting out, but usually the lessons about the relationships and the payment systems and the incentives from hospitals and physicians can still be applied and can be a really helpful guide. I'll just note that what we just talked about left pharmacies and pharmaceutical products aside for now. That's something I hope we'll find some time to talk about later on, but often it's its own category with its own set of payment and other issues, so that'll have to be separate.